Hello, this is Anthony Effinger. I'm the host of the Think Neuro podcast here at the Pacific Neuroscience Institute in Santa Monica. And today I have a double bill. I've got Dr. Barbara Geiser, who's a neurologist and is an expert in treating people with multiple sclerosis. And I have Dr. Howard Kraus, who's a neuro-ophthalmologist. And they're going to talk about the intersection of MS and vision. Thanks so much for being with me today.
Thank you, Anthony.
So where should we start?
Well, since I'm a man of vision, I can do the kickoff.
Fantastic.
But as we've noted before, 40% of our brain is involved with vision, both the visual perception and processing of visual images, acting upon what we see, and the regions of the brain that then control and coordinate eye movement. And recognizing that MS is primarily a brain disease, it's not surprising then that some MS patients will have visual symptoms. And in some cases, the visual symptom comes to be the first sign of MS. So I'm here today to note that Dr. Geiser and I have a wonderful collaboration here at the Pacific Neuroscience Institute, and one of the things that we pride ourselves on at PNI is our multidisciplinary effort. So we make it easy for patients to come to one center and see all of the specialists and have all of the tests done that they need, rather than to be going from building to building and time to time. So I'm here to assist Dr. Geiser in our MS program.
When I saw that we were going to be talking to both of you together, I was wondering what the connection was, because I knew your backgrounds. But now I see vision is often where we see the MS appear first, and it has massive effects on the vision system. So tell me, what are the signs you see that indicate MS in the vision system?
So visual complaints, as Dr. Kraus said, are common in people with MS, and about 20% of the time, the very first symptom that somebody has that turns out to be MS is a fairly sudden loss of vision, usually in one eye, usually with some pain, and this is called optic neuritis, or an inflammation of the optic nerve. If we go back a little bit, we remember that MS is caused by the immune system attacking nerves in the central nervous system. Central nervous system includes the brain, the spinal cord, and the optic nerve. So it's not surprising that visual complaints are going to be pretty common. So when we see somebody with optic neuritis, we can test a couple of things. We can look at what their visual acuity is. We can look at their pupillary responses. We can look in the back of the eye. Sometimes we can see the damage and sometimes we can't. But what's very useful is to have then be able to refer them to Dr. Kraus, because he can do a very special test called OCT.
Okay, and OCT is?
It stands for optical coherence tomography, and it was really a breakthrough invention in ophthalmology as far back as 20 years ago, although the technology has been refined. So with optical coherence tomography, we're able to see in great detail the lining of the back of the eye. We're able to see specifically, as it relates to MS, what's called the retinal nerve fiber layer. Each optic nerve has about 1.2 million individual fibers in it, which then enter the eye and course over the surface of the eye. And with OCT, we're able to measure the thickness of that retinal nerve fiber layer to detect swelling in the case of acute inflammation, and moreover to detect atrophy or loss of nerve substances. And we can also measure the thickness of what's called the retinal ganglion cell layer, where the cell bodies of the optic nerve lie on the surface of the retina. And we're able to see very small changes. You know, we marvel at the technology of MRI, but if we think of the ability to discern things on MRI, we're talking about changes of plus or minus a half millimeter, which is pretty small. In microns, that would be 500 microns. But when we measure things at the back of the eye by OCT, we're measuring things at 100 times that resolution at plus or minus 5 microns, which is the width of a red blood cell. So we're able to see much finer, smaller changes in OCT than we can in MRI. And in the management of the MS patient, the MRI is important, but we're also learning more and more that monitoring the OCT tells us a lot about the health of the optic nerve and a lot about the health of white matter in general.
What is tomography?
Tomography is a term that relates to looking at things in slices. So in OCT, or optical coherence tomography, we're able to look at different layers of the retina. The retina at the back of the eye is analogous to the film of a camera. In and of itself, it has the consistency of saran wrap, and its overall thickness is about 1/3 of a millimeter. But it has layers, and the innermost layer of the retina is the retinal ganglion cell layer and the retinal nerve fiber layer, which relates directly to MS and the damage done by MS.
Tell us about the difference between white matter and gray matter. I think most people know gray matter and they think of your brain, but MS is a disease that affects white matter. Let's talk about what that is and why it's different.
So most nerves have covered with a thick, fatty, white insulating material called myelin. Myelin's important because just like an electrical cable, the insulation helps the nerve conduct electrical impulses more quickly, more efficiently. In MS, the myelin is the first thing to be attacked, and so you've got, for all intents and purposes, a frayed nerve. The nerve is not conducting electricity, so if a muscle doesn't get the appropriate electrical impulse, the muscle's going to be weak. If you have a sensory end organ that doesn't get the appropriate electrical impulses, you might have numbness, or you might have crosstalk, and then you get like abnormal sensations. And in the case of the visual symptoms, if the visual pathways are not able to conduct the appropriate electrical impulses, you get loss of vision. There are other visual centers in the brain that control the ways the eyes move. And so if those nerve pathways are disrupted, you get double vision or bouncing vision or the inability to focus. So there's lots of visual symptoms that can present in people with MS. The very cool thing about OCT is that, as Dr. Kraus was saying, it can help us track nerve damage that doesn't produce any symptoms and that you can't see on an MRI or an exam. And so we could use OCT, for example, in addition to following the patient or following their MRI, we could also track serial OCTs and see if they're responding to medication.
Serial meaning when you keep doing them.
Periodically.
And you just watch for changes, so it gives you a clue to their overall health.
Well, it gives you a clue to the health of those pathways. It gives you a clue to the health of nerve pathways that may reflect other functions. So, for example, OCT, of course, is telling us about the visual pathways, but because it's concerned with the nerves in certain parts of the brain, there are studies that show that it actually reflects function of other neural pathways, such as cognition. There are studies that have shown that OCT can help correlate with cognitive function, which is another thing that MS can affect. So it's a very useful tool. And from the standpoint of the patient, it's a great test. It takes about 15 minutes. It's completely painless and non-invasive.
How do you do it? Is it one of these things where you put your face in the thing like at the eye doctor's office and they...
Exactly.
That's it?
And it's very simple, and it's painless, and simply requires looking at a crosshair in the machine, and then very quickly the machine scans the retina and produces the result for us. One of the marvels of this technology, and many technologies in general, is you learn as you go along. OCT was principally investigated as a better means of evaluating the retina in the analysis of retinal disease. But as we go along, we learn of its other applications. And in medicine, we have science and we have dogma. Dogma are the things that are written in textbooks that are carried down from generation to generation. And I love over time how we disprove dogma. When I lecture to medical students and residents, I often say to them, 50% of what you will learn in training will be later proven to be wrong. And it's your obligation to discern what is true, but also to always question so that we can discard the falsehoods and learn new pathways. So it was through OCT that we actually learned that things that occur in the brain are indeed reflected in the retina. The old dogma was if something happened posterior to that first connection at the lateral geniculate.
Wait, hold on. Let's stop there. So let's define our terms for me. Back of, posterior to...
The first connection of the optic nerve at the lateral geniculate. So if we think of vision, we don't see with our eyes, we see with our brain. Eyes are the cameras or the detectors, and the signal is conveyed into the brain through the optic nerve, which then makes a connection at the middle of the base of the brain in a structure called the lateral geniculate. And then there are other nerves that bring that visual information through the brain to the back of the brain to the occipital cortex where we see. So it used to be said that if something happens in the brain, we don't see any evidence of that when we look inside the eye. But about 10 years ago, it was discovered as we had the technology to look at the retinal ganglion cell layer, which are the cell bodies of the optic nerve, that someone could have a stroke in the brain, someone could have other damage in the brain, and then we see atrophy of the retinal ganglion cell layer. So that old dogma that something that happens in the brain is not seen in the eye was only because we didn't have the technology to look fine enough at the eye. So we've learned that, as Dr. Geiser noted, that OCT tells us many things about the brain that we didn't know that it had the potential to tell us.
How long have we had it? Is it about 10 years? Is that what?
Well, it's been refined over time. So I think the invention and application of OCT to looking at the retina is about 20 years old.
Okay.
But that's like saying MRI is 20 or 30 years old. You know, today's MRI is not the MRI of 20 or 30 years ago, and today's OCT is continuing to be refined. So it's just always elevating to have a new technology and to be able to learn from the use of that technology things that we didn't know before.
Fantastic. What happens when a patient comes in? Tell me about the kind of person who you would do an OCT test with, and what happens as the results go one way or the other.
Again, when somebody comes in with a visual complaint and optic neuritis, usually we can see some manifestations of that on exam, but again, it would be very...
Like?
So, again, optic neuritis most commonly produces a loss of vision. It's almost always in one eye, occasionally can be both eyes. So you would first check the person's visual acuity with an eye chart. How well can they see? You can look at their pupils. Sometimes there are abnormal pupillary responses. I can look at the back of the eye, which is called the fundus, with an ophthalmoscope, and you can see the head of the optic nerve. Sometimes you might see changes, sometimes not. So I can see some things on exam, but I can't get the discrimination that Dr. Krause can with an OCT with sophisticated visual field techniques. So that's why it's really so helpful to be able to say, go downstairs and see if Dr. Krause can see you and do an OCT.
And you have that. You have the machinery on. You have the on site.
Yes.
Okay.
As we said, the other reasons why I might have somebody see Dr. Krause is they're not having an acute attack of optic neuritis, but we know they have MS, and again, we know that MS can produce damage to visual pathways that may not produce symptoms. So we would have them see Dr. Krause so he can get sort of a baseline evaluation of how well their visual pathways are functioning, do a baseline OCT, and then we could track this over time. Some of the other symptoms that people with MS might have come, as we said, not from damage to the optic nerve, but from damage to centers in the brain that control the nerves that affect eye movement. So people might have double vision or bouncing vision, and I would refer them to Dr. Krause for any therapeutic interventions he might be able to do.
So Dr. Geiser and I have fallen into a pattern where if Dr. Geiser has an MS patient, we'll evaluate that patient, even in the absence of symptoms, on average once a year, measure the best corrected visual acuity, look at the pupillary reactions, do what's called visual field testing to test the peripheral vision, because sometimes optic nerve and brain problems will show up with a peripheral vision problem, not a central vision problem. Do the OCT test, take some photographs of the retina, and then also look very carefully at the eye movements. Because even without a complaint of double vision, we'll sometimes see abnormalities in the eye movements. So we'll look at the alignment of the eyes, we'll look at the speed of movement of the eyes, the smoothness of the pursuit movements. MS will often affect the cerebellum, which is a center of coordination, which can cause the eye movements to be a little bit jerky or irregular. It can affect the brainstem, where eye movements are initiated and controlled. So one of the hallmarks of a eye movement abnormality in MS is what's called internuclear ophthalmoplegia. And that's a miscoordination of eye movement where the signal gets to one part of the brain that, hey, we're going to look to the right, but it gets to the left eye slower than it gets to the right eye. So the eyes may be in alignment in a steady state of gaze, and there may be no double vision, but when the MS patient then looks to the side, one eye lags behind the other eye, isn't necessarily perceived as double vision, but is perceived as imbalance or a visual problem. So we can look at the regularity or irregularity of the eye movements and really do a full assessment of all of the visual components of the nervous system as they may relate to MS.
That's fascinating. Those are such subtle clues to this disease. And now a message from our sponsor. The Think Neuro podcast is brought to you by Pacific Neuroscience Institute Foundation, a nonprofit 501c3 organization. If you're inspired by what you hear and wish to support our mission of education through innovation, please visit pacificneuro.org/foundation. So when a patient comes to you, how often do you see a patient who doesn't suspect that they have MS or is not, it's never even come onto their radar, but they have an issue with vision, and that becomes the thing that says, you have MS?
So somebody with a purely visual complaint is more likely to see Dr. Krause before they see me. And then Dr. Krause would probably very astutely order an MRI of the brain. And if that shows scarring consistent with MS, that's probably when I'd be called in.
Okay, so I was wondering what the order of operations was there, and I can imagine
it really
goes both ways.
It really goes in both directions.
Yeah.
There was a hallmark study that was initiated in the late 1980s called the Optic Neuritis Treatment Trial, where about 500 individuals with first attack of optic neuritis were randomized into 3 treatment groups: high-dose intravenous cortisone, oral cortisone, and no treatment.
Cortisone, it's steroid?
Yes.
Okay. And the idea there is to knock down the immune
Inflammation.
inflammation?
Right.
Okay.
And we learned many more things from this study following it over 15 years plus than we thought we would. So we learned, for example, that the best treatment, if it's going to be treated, is high-dose intravenous cortisone for a few days. That, in fact, patients who were treated initially just with oral prednisone were found to have a higher rate of recurrence of optic neuritis. And the patients who weren't treated at all got better as well. So one of the interesting things about that is at 1 year after the attack of optic neuritis, all 3 treatment groups had the same level of vision. But the other thing that was discovered, because all of these patients were followed with MRI, is that if an individual had one bright spot in the white matter on their MRI when they presented with optic neuritis.
Wait, a bright spot meaning?
An area of nerve damage.
Got it.
So even with one bright spot, one abnormality on the MRI, which was clinically silent, no other symptom of MS, that half the time that individual would go on to develop clinically diagnosable MS. And furthermore, those patients who had completely normal MRIs, 10% of the time, would still go on to develop MS. And overall, those patients who presented just with optic neuritis over a 15-year period, 70% of the time would go on to develop MS. So optic neuritis in and of itself is a harbinger of MS in a large number of cases. So through a clinical controlled prospective trial, we learned more about the disease and we learned more about the treatment of the disease. Now comes along greater technology and greater knowledge, and we have a finer diagnosis of other things that can produce optic neuritis other than MS. There's also a more rare neurologic condition called neuromyelitis optica and some other unusual autoimmune conditions called anti-MOG and anti-GFAP. And when those other conditions cause optic neuritis, the concern is that in the absence of treatment with cortisone, that some of the other demyelinating autoimmune diseases have a higher risk of causing permanent damage to the vision. So whereas the optic neuritis treatment trial told us that their visual recovery was no different whether or not you treated, especially in something like neuromyelitis optica, we've discovered that if you don't treat, that individuals at higher risk of permanent damage. So the standard of care in optic neuritis nowadays has shifted to trying to treat everybody with at least a few days of high-dose intravenous cortisone until we figure out what their underlying diagnosis
On the
is.
off chance that they've got this rare condition that calls for treatment.
But the good news is that even though optic neuritis is very much associated with autoimmune demyelinating disease, that Dr. Geiser is here to figure it out and to treat all of those patients. So we think about whether or not to use cortisone, but there are many other very effective, helpful drugs in the management.
Yeah, let's talk about those.
So we have to think about treating acute episodes, and an attack of optic neuritis is an acute episode. And as Dr. Krause said, we would normally give several days of high-dose intravenous corticosteroid. If that doesn't work, sometimes there are some second-line treatments we can do. We do a procedure called plasmapheresis, which is literally washing the blood. So we extract blood from people, we wash out the antibodies, the kind of bad humors, and then we give them back the blood, and that works sometimes.
How much blood are we talking about there?
You do a plasma exchange. You take out a certain volume of blood. It goes through a machine. The soluble part of it, which is where all the antibodies and the pathogenic proteins are, gets washed out, and then you return back the patient's white cells and red blood cells. Plasmapheresis is used for a number of autoimmune conditions, but we use it as a second-line treatment when people have not responded to steroids.
Do you do that once, or is that a...
You do it over a course of several days. You give several treatments over a course of
and then
3 to 5 days.
And then you see how the patient does, and
right, exactly.
Whether or not you need to do it again sometime in the future?
Well, it's an acute treatment, so
Okay.
we have to differentiate between treating an acute attack and maintenance, what we call disease-modifying therapies, and those are a different class of drugs. So again, if we get back to what's the problem here, the problem is in MS and in these other diseases that can cause optic neuritis, Dr. Krause was mentioning, neuromyelitis optica and anti-MOG syndrome, you have an immune attack on nerves in the brain and the optic nerve and the visual pathways. So you want to give chronic, sustained therapy to kind of beat back the immune system and stop it from attacking the nerves. And for MS, we now have almost 24 FDA-approved disease-modifying therapies that can do this. And in the case of NMO, over the past year or so, we actually have 2 FDA-approved therapies that are specific for neuromyelitis optica. So I think the other thing, we were talking about technology and how we can do all these great things. We can get finer resolution with less invasive tests. And the sea change in the field of MS and other autoimmune conditions is over the past 25 to 30 years, we've had the development of these disease-modifying therapies that actually abrogate the natural history of the disease. When I started working in the field of MS, which is longer than I care to comment on, when we saw people who had optic neuritis, we couldn't even do MRI. We suspected that they had MS. And we would say, well, we think we could do a spinal tap, and sometimes that was helpful. And we would say, well, you have MS, and I can give you some corticosteroids for this attack, and take it easy, and let me know if you need any physical therapy. And now, because we have these remarkable technologies, because we have MRI, because we have OCT, because we have new diagnostic criteria that help us diagnose, and we even have blood tests for things like NMO and anti-MOG, which we don't have.
The 2
for
rare
MS.
conditions,
Yeah.
right.
You can pick up the antibodies in the blood. And now we can diagnose people early. We can say, look, this is what you have. These are your choices for treatment. And we also, of course, know the importance of combining a healthy lifestyle to work with our pharmacologic strategies.
So there's no cure for MS, globally here, but there's lots of treatment for the episodes that happen when one has MS.
We have treatment for the acute episode, but
Yeah.
we have disease-modifying therapies that help prevent the likelihood of more attacks and future damage.
Right, okay. So that's got to be wonderful.
It was a sea change.
Because when I was growing up, we knew folks with MS, and it was like, well, good luck.
Now that's really the take-home message of anything we're going to say about MS. It's a treatable and controllable condition.
So for you, that must be, and for your patients, this must be a new world.
MS is a scary thing, and I think we now have the ability to make it a lot less scary.
When an MS patient has neuritis in the optic nerve, what's their expectation? Is this going to be one of these where it comes on, you tamp it down, it comes on again? If you get it once and you're likely to have it again, what do you tell them about their expectations?
Well, one of the scary things about MS is every young person has an image in their mind of being blind or being disabled or wheelchair bound. And nowadays that really is a minority of MS patients. So I think that even in the long run, 90% of people who have an attack of optic neuritis, which could be very severe, they could have almost no vision in the heat of the attack, but 90% of patients with MS maintain good vision throughout their life.
90% of patients.
And it's a small percentage that become disabled and dependent. What number would you say that may be?
I couldn't give you an exact number, but it's certainly much, much less than when before we had the disease-modifying therapies.
Part of being a physician is doing your best to harness the technology, make the diagnosis, and deliver the appropriate care to the patient. But just as important a part of being physician is taking care of the anxiety and the fear of the patient. And having all of these tools that Dr. Geiser notes makes us more optimistic, and we're eager to share that optimism with MS patients that we'll help you with this, and we'll give you the therapy that you need, and we'll modify the therapy that you need. But the outcomes are much better today than they had been decades ago.
Mm-hmm. Sure.
What I find myself telling people who are newly diagnosed is there's never a good time to have MS, but if you have to have it, now is the best time there ever was. And so our current therapies are really pretty good at stopping damage and preventing future attacks. The next great frontier in MS is going to be repairing the damage that's already done. And we're not there yet, but there are a lot of things going on in preclinical trials and animal models. There are a few trials in humans showing that this is possible. And so that's going to be the next great leap. So I don't know, but in now I can say to people, we can control this disease. And what I'm hoping is that maybe in 10 or 20 years, we're going to say, we're going to control this disease and we're going to reverse it.
Repair this damage to the myelin. You said that, you talked about how in MS the immune system attacks the myelin. Does it attack other things, or is it solely that?
So the initial attack is on the myelin, but the nerve wire, what's called the axon, which is what the myelin wraps around, can be damaged as well. And so initially you have degradation of the myelin, and over time you have damage and dissolution of the axon as well, and that's when you get more permanent damage.
And that manifests itself obviously in...
So that's when people tend to have less recovery from attacks and they have more progressive deficit. That's why we want to get in early. When we get in early with these disease-modifying therapies, we not only try to preserve the myelin, we try to preserve the myelin-forming cells. Those are called oligodendrocytes. And so we want to get in and save those oligos and preserve that myelin and protect that axon.
So the oligos are...
The myelin-forming cells.
They're making
myelin.
Okay, and so you can preserve the factory then.
Well, that's part of it. You're trying to preserve existing myelin, and you're trying to preserve the cells that make myelin, because we know that especially early on in MS, the brain has innate repair capacity. So if you damage myelin, the brain will jump in and try to repair it. But over time, if you lose those myelin-forming cells, you have less capacity for repair.
Oh, sure, yeah.
Our reparative strategies they're sort of a twofold strategy. You want to try to promote the innate repair capacity of the brain, and then you might want to bring in exogenous things that will also affect repair.
Exogenous, like?
I mean, there are lots of things that people are trying right now.
Fantastic. So this is really we've come so far. I mean, I feel like the last time we talked about MS, it's changed in a year.
I don't know that it's changed it, but well, we learn new things every day, as Dr. Krause said. But the point is that, as with many neurologic diseases, it kind of takes a village. Certainly, neurologists can't do it by themselves, so it's really a gift to be able to have the close collaboration with neuro-ophthalmology.
Did you ever think, say, 10 years ago or 15 years ago, that you'd be collaborating this way? I mean,
well, many of us have always sought collaboration, but we were at universities and other institutions where the distances and the layers of bureaucracy were too difficult to make it an efficient, pleasant experience for patients. And really the thesis of the formation of Pacific Neuroscience Institute is to bring all of the neurodisciplines together in a geographically close and collaborative relationship to make it easy for patients to see all of those specialists who can coordinate and participate in their care. The other thing we learn, which is very exciting, is that by working closely together, we come up with new ideas and new opportunities for clinical trials and research that can create better therapies going forward.
Sure. Corporate America is right now, everybody's at home, working at home, and people are worried that, you don't get the meeting on the stairway where, two employees who work in different parts of the company get together and suddenly you have an idea. You must have lots of sort of stairway inspiration here. I mean, this 3-story building, you're all in here. I mean, you can't discount the value of those random meetings, right? I mean, how often are you just sort of kicking things around and then something comes of it?
It's every day. I see something interesting or exciting on the first floor, and I can call Dr. Geiser on the second floor or Dr. Kelly or any of our other colleagues and say, can you please come down here? And it's better for the patient, it's more exciting for us, and it leads to better insight and better clinical trial development.
So tell me how you organize this. What's on the first floor?
First floor is ear, nose, and throat,
okay.
Neuro-ophthalmology, and a brand new infusion center we have. Many of the therapies that we can administer to patients today, including therapies for MS and neuro-oncologic diseases and other autoimmune diseases, are administered intravenously and need to be done slowly over time with nursing supervision. So we're able to do that here on site rather than to have to send someone off-site to an infusion center. And then the second floor is neurology and neurosurgery. And then close by, 2 blocks from here, we have our brain health center where Alzheimer's patients and Parkinson's patients are evaluated and treated. So everything is near and at hand.
So there is something to this meeting in the stairway.
Yes.
Yeah.
Yes.
I think that's fascinating. I think it's a fascinating notion, and I do think it's something that gets lost when people aren't in the same building.
I agree.
I think that kind of collaboration is, you can foster it, but a lot of it's just luck of the draw.
Yeah, we learn a lot from one another.
Yeah.
Well, and the other thing that's really great for the patients is a kind of one-stop shopping concept. So again, and Dr. Krause and I shared a patient a couple months ago. It was a young man who had a first attack of optic neuritis. Dr. Krause saw him and gave me a yell upstairs and said, come down and see this gentleman. And I did. And I was able to review his MRI, and I was able to say, we've put together your MRI and your clinical presentation. We think you have MS. And so that day
Wow.
I was able to sort of start him on a therapeutic course. Dr. Krause was talking about our brain health center. We're just developing, starting a on-site physical therapy rehabilitation program. That's going to be really exciting because many of our patients with MS need physical therapy. So they can come here to PNI and get neuro-focused, neuro-expertise rehab, which is a really exciting concept. And we're hoping to extend this to other areas of rehab as well. So we really do envision PNI as kind of a place that can meet many neurologic and neurosurgical needs.
So this young man came in with an eye complaint, and so he saw you, and then he also, that very same day, saw you and found and you determined the diagnosis of MS.
And we were able to start him on his therapeutic regimen. So that's what it's all about.
Yeah, yeah. Well, and how long have you been going here now?
You know, it's interesting. I've known of Dr. Geiser for quite some while because many of my MS patients would say, "Hey, I found this great neurologist, Dr. Geiser," so I knew of Dr. Geiser's reputation long before we met and started working together.
But they hired me anyway.
And it was personally exciting for me when Dr. Geiser joined us recently. So
How long has it been?
A year and a half.
That's it.
right.
Fantastic.
And I certainly knew of Dr. Krause before I came here.
But if you look at P&I in general, we're young.
Yeah, you are.
You know, many of our doctors have known each other for decades, but in terms of putting together the P&I as a collaborative institution, it started in 2017. We modified and occupied this building, our first center, in 2018. And in the space of a few years, we've grown from 4 physicians to 34 physicians. And over the next year and a half, we're recruiting another 17 more.
17 more.
All neuro specialists in psychiatry, neurology, neuro-ophthalmology, neurosurgery, interventional neuroradiology. So we have the good fortune of being recognized as a valuable resource for the community and being supported to grow very rapidly. It's very exciting.
Where are you gonna put all these people? I mean, it's not a huge building. It's big, but
Well, just as OCT allows us to see things that are very small, we've discovered how to shrink things down. So everybody is here in this one single 10,000 square foot building. Now, we have a wonderful collaborative relationship with Providence Healthcare, which has 10 hospitals in LA and Orange County, and terrific support from the St. John's Health Center Foundation and other foundations. So we refer to what's called the power of partnership, where we've got the physician leadership, the hospital leadership, the foundation leadership, and it's really providing the fuel for us to expand in more clinics and more centers throughout LA and Orange County.
yeah. So that, it doesn't all have to.
It's not all in this one building.
Yeah, nobody's going to be standing at counters with their laptops or.
Right.
Yeah. Okay. Well, this is delightful. I'm so glad to catch up with you, and I think maybe in a year we'll do it again and learn
Great.
more about the progress.
Thank you.
Thank you.
Dr. Geiser, Dr. Krause, thanks for joining us.
Thank you,
Pleasure.
Anthony.